really wanted to talk about was the pediatric hospital medicine model that we have in the United States and that is growing in the United States. Not necessarily because we feel that everybody needs to do it, simply because we feel it's the right choice for us, and so we'd like to share some of the lessons that we've learned and some of the things about how we do things in pediatric hospital medicine model, so that anybody we talk to about this, we can share our lessons and learn from each other, as well as maybe pass on a message of something that I think, in my opinion, is coming in pediatrics, that it's already fairly advanced in adults. So we're going to just talk about general perspectives about pediatric hospital medicine. A little bit of the history, because I think it's important to know where it all started, how it's currently organized in the United States, and some of the activities and accomplishments of pediatric hospitalists, which are not that many because we're very young. So let's start by defining the, you should always define the problem. Well, I don't think hospitalists are a problem, but let's define what they are. So what is a hospitalist? And this is an adult or pediatric hospitalist. Well, the first definition came from the person that everybody considers sort of the father of pediatric hospital, or of hospital medicine, Dr. Robert Wachter from California, who defined hospitalist initially as somebody who works in the hospital at least 25% of their time, where they are the physicians of record who accept the patient who comes from the emergency room, from the clinic, but then they give the patient back. And that's the very important concept of a hospitalist, is they give the patient back to their primary care provider. That definition is nowadays somewhat historic. The process of giving the patient back is not. That's still a very accepted concept. But the definition of hospitalist is now established by the Society of Hospital Medicine, and they are a physician whose primary professional focus is the care of the hospitalized patient. But besides that, a lot of their activities outside of clinical settings are teaching, research, and leadership. In other words, trying to make the profession of hospital medicine better. And what is a hospitalist program? Well, that is a little bit harder to define because there's lots of different models. For pediatric hospital medicine programs, there's several models. The most common one is the academic hospital medicine model, which is basically you are part of a university, you work mostly at a tertiary care children's hospital, and some of them work in community teaching hospitals, but most of the time you're going to see the large academic centers, such as a large university such as Baylor College of Medicine, whose physicians work at a children's hospital. That's one of the models. The other model is full-time hospitalists that work in a non-teaching hospital where there's no residents. And basically, that rarely is a children's hospital, but most of the time is a pediatric ward within a hospital. Jack Pursley, who's one of the sort of pioneers in pediatric hospital medicine, published a statement in Pediatrics in 2005, along with other well-known authors in pediatric hospital medicine, that said they recognized that pediatric hospital medicine was growing as a field, and decided to create a set of values or a set of guidance from which to guide the field. And one of them is that doctors who refer patients to pediatric hospitals should do it on a voluntary basis. We should not have to force pediatricians or other community hospitals to give the care of their patients to us. It should be voluntary. If they want to see their patients in the hospital, they can see their patients in the hospital. So it should be voluntary. Hospital medicine programs should be designed for local needs. So there should only be a hospitalist if really your local needs require hospitalists to be there. And I think more and more in the United States we found that that's the case, that in most cases pediatric hospitals are needed, or at least they're wanted. That they should have at minimum a training in pediatrics. So you shouldn't be a pediatric hospitalist if you're a family medicine doctor or if you're an internist. You should have at least minimum training in pediatrics. That amongst your work you should include appropriate follow-up. So you shouldn't just be responsible for the patient while they're in the hospital. You should make sure that they have somewhere else to go after the hospital. That there should be timely and complete communication. That basically, once you give me your patient to take care of in the hospital, I should tell you what happened with your patient very fast and very efficiently. And I should let you know the course that the child had during his hospitalization. So timely communication between the hospitalist and the primary care provider. And that we should be collecting data. That means we need to know if we're doing a good job. Are pediatric hospitalists really making a difference? And so we should be collecting data. So what do we do? What do pediatric hospitalists do? Well, there's a whole range of things that they do. Most of them, they work in the inpatient units, basically the pediatric ward, either of a children's hospital or of a children's ward within an adult hospital. Some of them work in the emergency room. Lots of them work in the newborn nurseries and in labor and delivery when the children are born. There's a specialized group of pediatric hospitals who are neonatal pediatric hospitalists who do this work a lot. A lot of large pediatric hospital medicine programs have this in their job description. Gita and I don't do this, but other hospitalist programs do. This is more true of adult hospitals. Adult hospitals work a lot in ICUs. Some pediatric hospitalists work in ICUs, but the pediatric ICU has really been dominated, at least in the United States for now, by pediatric intensivists. They really are the ones that cover that mostly, although a lot of pediatric hospitalists are being asked to cover gaps. Whenever there's not an intensivist, pediatric hospitalists are asked to cover those gaps. And surgical co-management is something that we do at Texas Children's, and lots of pediatric hospitals do, in which we take care of the patient while they're in the hospital, and the surgeons basically only take care of the surgical issues that arise. So mostly they handle whatever happens in the operating room, but after the operating room, we take care of it. And it's co-management. Basically, we work together with the surgeons. And when I say together, I don't mean just in the clinical sense. I also mean in the financial sense, that we both, work with each other so that we can each do financially well with managing patients in the hospital together. Hospitalists provide sedation services whenever there's no anesthesiologist to provide a sedation service. A lot of hospitalists, one of the largest programs for sedation services for hospitalists is the St. Louis Children's, and they really provide lots of sedation. Every MRI that is done in a child, an MRI, they have to be very still. It's a pediatric hospitalist who's providing their sedation. Some pediatric hospitals do inpatient and outpatient consults. They have a clinic, and usually those clinics are clinics in which kids have difficult diagnoses. And because as pediatric hospitalists we tend to see complex patients, sometimes we get involved with diagnostic workups. And whenever there's a community hospital, a large community hospital, pediatric hospitals may be the only pediatricians at that hospital. And so they can sometimes be the only pediatric voice in a community hospital. So why do we exist? Why do pediatric hospitals exist? And what has influenced the growth in the field? It's true in the United States. I think it's one of the factors that if pediatric hospital medicine becomes a model somewhere else, a lot of these factors are going to be the same factors. So